Welcome back to the Deep Dive. We're your shortcut to staying ahead in, well, a world just bursting with information. Today, our mission, as always, is to cut through all that noise and really reveal what's truly transformative in the latest radiological research. We want to make sure you're equipped with the insights that are going to shape your practice. So we're essentially talking about making the unseen visible, unlocking hidden pathologies across the body.
Exactly. And for you, listening as radiology residents, this deep dive, it isn't just about, academic curiosity. It's really about understanding the very tools that are fundamentally changing non-invasive diagnostics and ultimately patient care. We're sort of on the cusp of a revolution here, moving radiology closer than it's ever been to truly personalized precision medicine.
And what a week it's been for breakthroughs, seriously. We picked out 3 truly cutting-edge papers from just the past few days. We're going to take a journey through the body, starting with the liver, then heading to the brain, and finally the heart. We'll explore how innovations in MRI, advanced ultrasound, and this really powerful emerging field of radiomics are leading the charge.
Right. And radiomics, maybe for those newer to the term, it's essentially about extracting just vast amounts of quantifiable data from medical images. We're talking data that's often invisible to the naked eye, and then turning that data into actionable insights.
It's almost like finding a hidden language within our images, isn't it?
That's a great way to put it, yeah.
Okay, so buckle up. We're about to unpack some truly incredible science. Let's kick things off with the liver. And a condition that's becoming a huge global health crisis, metabolic dysfunction-associated steatotic liver disease, or MASLD. This paper, it's hot off the presses from the New England Journal of Medicine, just out on August 13th. It paints a really clear picture of its growing burden. We know MASLD can progress quite insidiously, right? From simple fat accumulation to inflammation, fibrosis, cirrhosis, even hepatocellular carcinoma. And the recent renaming, shifting away from non-alcoholic to emphasize the metabolic dysfunction, that really highlights the systemic nature of this disease, doesn't it?
It absolutely does. And what's critical for us, and especially for you as residents, is the challenge MASLD presents because it progresses so silently. We absolutely need to identify at-risk AMASH, that's the metabolic dysfunction-associated steatohepatitis, with clinically significant fibrosis, usually stage F2 or higher. We need to find it before it leads to irreversible damage.
Right, and historically that meant?
Well, historically, the gold standard for this has been the liver biopsy, which, as you know, is invasive, it carries risks, and frankly, it has limitations in sampling. You might miss the spot. So early, accurate, and non-invasive detection is just paramount for effective patient management. And that's precisely where imaging is now stepping up in a pretty revolutionary way.
Okay, so for a resident seeing these patients, maybe in clinic or reviewing scans, what's the real game changer here? How are these advanced imaging techniques really empowering us to move beyond the biopsy and catch these critical stages earlier?
It's a complete paradigm shift, honestly. We're moving towards a future where a liver biopsy for NASLD might become the exception, not the rule. The paper highlights 2 cornerstone techniques. First, you've got MRI-based methods, specifically MRI proton density fat fraction, or PDFF.
PDFF.
Think of PDFF as a highly precise quantitative sort of thermometer for liver fat. It gives you a non-invasive, really accurate way to quantify liver fat content. You get a number, not just a subjective visual guess. And that's crucial for both diagnosis and, importantly, for monitoring how well treatment is working.
Got it. Measuring the fat precisely. What else?
Then we have elastography. Now, this isn't about looking at structure so much, but about measuring tissue stiffness. Stiffness is a direct indicator of fibrosis severity, how scarred the liver is becoming.
Right.
And we have 2 main players here. Vibration-controlled transient elastography, or VCTE, you might know it as a FibroScan, which uses a little mechanical vibrator on the skin to generate a shear wave. And then there's magnetic resonance elastography, or MRE. MRE uses a transducer outside the body to create these gentle mechanical waves within the liver, and the MRI tracks how those waves travel.
Okay, so VCTE and MRE, different ways to measure stiffness. Is one better?
Well, both provide quantitative measurements, but what's really interesting is that MRE in particular has shown, often superior diagnostic accuracy for detecting significant fibrosis compared to VCTE in quite a few studies. It tends to be a bit more robust.
Wow, that's huge. So instead of a patient having to go through an invasive procedure with all the risks and discomfort, we can get a precise fat measurement and a reliable stiffness reading all from a scan.
Exactly.
It means we're not just seeing if there's fat, but how much, and crucially, if there's significant fibrosis developing. That must dramatically change how we approach these patients day to day.
Absolutely. For you, as radiology residents, these aren't just, abstract techniques you read about. These are becoming central tools in the MSLD diagnostic flowcharts, like right now. They enable earlier, much more accurate risk stratification. Imagine being able to confidently identify that at-risk MSH patient, the one who might otherwise need a biopsy, and you can do it non-invasively. That allows for prompt therapeutic decisions, maybe getting them into clinical trials for new therapies faster.
Yeah, I can see that.
So it means you can guide treatment decisions with much greater confidence. And you can monitor their response to interventions without needing repeated invasive procedures. It really offers more personalized care, and it's significantly less burdensome for the patient. It's all about intercepting that disease progression with unprecedented precision and, frankly, patient comfort.
Okay, incredible progress in the liver. Let's pivot now from the body's largest internal organ to, well, arguably its most complex, the brain. Specifically, we're diving into the lingering mysteries of long COVID. We've all heard about the persistent and often really debilitating neuropsychiatric symptoms, that infamous brain fog, memory issues, fatigue. For too long, the underlying biological mechanisms behind these symptoms have been incredibly difficult to pin down, haven't they?
Indeed. It's been a major blind spot. We know the blood-brain barrier, the BBB, plays an absolutely crucial role. It's the brain's highly selective gatekeeper, regulating what gets in and out from the blood, protecting the central nervous system. Now, disruption of this barrier has been suspected in various neurological conditions, and yes, including long COVID. But the previous methods we had for assessing its integrity were often invasive, injecting contrast agents, or maybe just limited in scope. They didn't give us the full picture, making comprehensive, long-term assessment a real challenge. We really needed a better window into this vital protective system.
And a new technique is providing just that window, right?
Yeah.
How is this groundbreaking imaging method allowing us to finally peer into the BBB with such unprecedented detail, especially for something that can seem as subtle and persistent as long COVID symptoms?
That's exactly where this groundbreaking paper from Brain, Behavior, and Immunity dated August 15th comes in. It introduces a truly remarkable technique called water extraction with phase contrast arterial spin tagging. It's a mouthful, so let's call it WEPCAST MRI.
WEPCAST MRI. Got it.
What's genuinely revolutionary about WEPCAST is that it's non-contrast and completely non-invasive. Instead of injecting an external contrast agent, it actually uses the body's own water as an endogenous tracer.
Water? How does that work?
Think of it like using the brain's natural plumbing system as a tiny, invisible spy. WEPCAST tags this water while it's still in the arteries supplying the brain. Then, it precisely measures how much of that tagged water leaks or extracts across the BBB into the brain tissue itself. Because you're measuring water, the most fundamental tracer of all, it makes the technique incredibly sensitive, even for very subtle disruptions in the barrier's permeability. It allows for far more precise permeability estimation than using larger contrast molecules.
Wow. So it's detecting tiny leaks just using the water already there. What did they find in the long COVID patients?
Well, the key finding from this study was really illuminating. WEPCAST MRI revealed significantly higher BBB permeability in the long COVID patients compared to controls who had recovered from COVID.
Higher permeability, meaning a leakier barrier.
Exactly. And this isn't just a fleeting disruption either. They found it persisted even more than 2 years after the initial infection. And here's the crucial link they found. This higher BBB permeability was significantly associated with poorer motor function in these patients.
Motor function, not just cognitive fog.
Right, poorer motor function specifically. So this isn't just about seeing a leak. It seems to be showing us a biological fingerprint that connects to tangible neurological symptoms, in this case motor issues, potentially contributing to things like fatigue or movement difficulty sometimes reported.
So, if I'm understanding this correctly, WEPCAST gives us a tangible, measurable biological marker for conditions like long COVID, which have often felt, well, largely amorphous and hard to pin down objectively. For a resident, that means we're potentially moving beyond just symptom description to actually identifying an underlying measurable mechanism. What's the significance of having a tool like this for future diagnostics, maybe even therapies?
Oh, this is a monumental step. WEPCAST MRI presents a truly powerful, non-invasive tool to assess BBB integrity precisely and, importantly, repeatedly over time. It identifies these subtle, persistent BBB disruptions in long COVID. It could potentially serve as a long-term biomarker for neuropsychiatric complications, maybe especially this motor dysfunction component. Imagine a future where we can use WEPCAST to objectively diagnose BBB pathology in long COVID patients. We could use it to monitor the effectiveness of new treatments aimed specifically at restoring barrier function, maybe stratify patients for targeted interventions based on their BBB status.
That opens up so many possibilities.
It really does. It opens new and exciting avenues for diagnosis, for monitoring, and critically for developing treatments in a really challenging clinical area that has, until now, lacked these clear, objective biological targets. This could fundamentally change how we understand and manage not just long COVID, but potentially other complex neurological disorders where BBB involvement is suspected.
Truly fascinating. Okay, from those subtle, persistent disruptions in the brain, let's shift our focus now to the heart, and specifically to one of the most acute and life-threatening conditions we face, acute myocardial infarction, or MI, or a heart attack. MI obviously remains a leading cause of morbidity and mortality globally. And we rely heavily on conventional echocardiography, ultrasound of the heart, as a primary imaging modality, especially acutely. But directly identifying and precisely quantifying the infarcted tissue, the damaged heart muscle, with standard echo has always presented a significant challenge, hasn't it?
It really has. With conventional echo, we often infer the presence of an infarct based on things like wall motion abnormalities or thinning, but direct visualization and detailed characterization of the tissue itself can be elusive.
Right. See the consequences, but not always the tissue damage itself clearly.
Precisely. And that's where this really innovative concept of ultrasomics comes into play. This is detailed in the JACC, Cardiovascular Imaging paper that just came out on August 20th. This is an exciting leap. Think of ultrasomics as a cardiac ultrasound-based radiomics technique. It takes the raw data from your standard echocardiogram, the same images you acquire routinely, and uses AI to extract high-throughput, pixel-level information. We're talking about information that's literally beyond what the human eye can perceive in the texture and pattern of the pixels.
So it's digging deeper into the image data itself.
Exactly. It's like turning that moving grayscale image, which we interpret visually, into a highly detailed spreadsheet, revealing hidden patterns and data points within the texture of the myocardium, patterns that even the most trained human eye might never spot manually. It transforms these traditional images into structured, mineable data sets that are just ripe for AI analysis.
That's a fascinating analogy. So it's not just looking at the overall shape or motion of the heart wall, but really delving into the microscopic texture of the tissue itself, almost like a digital biopsy, but with ultrasound.
That's a good way to think about it, yes. It's moving from that macroscopic interpretation, how the wall moves, to a micro-texture analysis. How does the tissue look at a pixel level?
Okay, so how does this AI-driven approach actually work with standard echo? How does it give us that unprecedented view?
So ultrasomics uses sophisticated machine learning algorithms. These algorithms are applied to features extracted from your conventional 2- and 4-chamber echo views, the standard views you get. Now, these features are a combination of two types. Some are handcrafted features, things perhaps related to texture that engineers have defined mathematically, but increasingly they also use features derived from deep transfer learning. This is where the AI essentially learns its own, often highly complex, features directly from looking at vast data sets of echo images. It figures out what patterns are most predictive.
Okay, so it's learning the important features itself. And what did the study find? How well did it work?
Well, the key finding was truly impressive. The machine learning models they trained on these ultrasomics features showed significant diagnostic value for detecting acute MI. They achieved an AUC area under the curve of 0.87 in distinguishing healthy from infarcted myocardium. That's very good performance.
0.87. Okay, that's strong.
Yes. And what's more, and this is really crucial for clinical practice, ultrasomics provided independent predictive value for MI, meaning it added diagnostic information even after they accounted for conventional echo parameters like longitudinal strain or LS.
So it's not just repeating what strain tells us, it's adding something new.
Exactly. It's offering entirely new information derived from that texture analysis. And get this, it could even differentiate acute MI in patients who already had existing myocardial dysfunction. You know, those tricky cases where their baseline longitudinal strain might already be low, less than 16% maybe. Ultrasomics could still pick up the acute infarct in that setting.
Wow, that is a notoriously challenging group to assess with conventional methods.
It is, and furthermore, the technique facilitates parametric visualization of the infarcted myocardium. It can essentially create color maps overlaid on the echo image, highlighting the areas of infarct. offering insights that are kind of akin to what we traditionally get from LEAP gadolinium enhancement on cardiac MRI, but now potentially at the bedside with ultrasound.
That sounds incredibly powerful. You're effectively bringing CMR-level tissue characterization insights to the bedside non-invasively with echo. For a radiology resident maybe working in the ER or CCU, this could dramatically change how quickly and accurately they can help diagnose an acute MI, especially in those ambiguous cases, right?
Right.
What are some of the immediate challenges or maybe learning curves they might anticipate in bringing this kind of AI-driven analysis into their daily workflow?
Oh, it's potentially transformative. For you, as residents, ultrasomics offers a really significant leap in early MI diagnosis and precise tissue characterization. The immediate challenge, if you want to call it that, is probably less about mastering new scanning techniques because it uses standard echo images, and more about understanding the power and, importantly, the interpretation of these AI-derived insights. What does this texture map mean? How reliable is it? But the beauty is that it can potentially be integrated directly into existing ultrasound systems for automated analysis.
So the machine does the complex analysis part.
Ideally, yes. This means less of a learning curve for image acquisition and more focus on understanding the output. How does this information help localize the infarct more precisely? How does it identify MI in those complex cases where conventional metrics might be borderline or confusing? And how does it ultimately inform immediate treatment decisions? By providing faster, more objective, and more detailed information about the tissue state, it absolutely has the potential to improve patient outcomes by enabling quicker and more targeted interventions. It's really augmenting our human expertise, allowing us to see what was previously invisible within the heart muscle itself on an ultrasound.
What an incredible journey we've taken today, really. From uncovering silent liver disease using MRI-PDFF and elastography to finally getting a glimpse of the hidden biological fingerprint of long COVID brain fog with WEPCAST MRI, and now decoding the heart tissue itself with this revolutionary AI-driven ultrasomics. It's just abundantly clear how these advanced imaging techniques are truly making the previously hidden visible, isn't it? Pushing radiology firmly towards that future of true precision medicine we talked about.
Absolutely. The profound impact these non-invasive techniques have for patient care just cannot be overstated. I mean, really. They offer faster, more precise diagnostics, often with significantly less burden on the patient, avoiding biopsies, avoiding contrast in some cases. And critically, they often allow detection at earlier stages of disease when interventions can be more effective. It truly reinforces the increasing, and I'd say pivotal role of AI and radiomics in our future radiological practice. These are providing us with tools that augment our own human expertise, allowing us to see more deeply and more quantitatively into the body than ever before. These innovations, they aren't just incremental improvements, they really represent fundamental shifts in how we diagnose and manage disease.
So, as radiology residents listening to this, really consider how these technologies will integrate into your daily workflow. Think beyond just seeing them as new tools, but as potential new ways of thinking about disease. How might they optimize your imaging protocols? How can you leverage these deeper insights to provide even more precise and actionable information for your clinical colleagues? How can you fundamentally change the patient journey with this information?
And maybe here's a provocative thought for you to reflect on as you move forward in your training and career. You're truly at the cusp of a revolution where the unseen is becoming visible with just unprecedented detail. Beyond these examples in the liver, brain, and heart, what new hidden pathologies do you anticipate advanced imaging will uncover next? What currently invisible disease processes might we soon be able to see? And how will that truly transform patient care in your chosen specialty, perhaps even redefining what we consider diagnosable today?
Lots to think about. We definitely encourage you to deep dive into these papers yourselves, discuss them, share your thoughts with your colleagues. The future of imaging is unfolding right now, and you're at the forefront.